Okay, hopefully you guys can hear me. I do want to echo Dr. Cantor's words. I feel very privileged to be invited to speak today. For those who don't know me, I am a pediatric cardiologist at the Stollery Children's Hospital and currently the director of the Heart Failure and Cardiomyopathy program. So today I'm going to look at pediatric mechanical support, but really we're going to focus mostly on bad therapy. These are my disclosures. So over the course of today's talk, we're going to look at a little bit about the background of ventricular assist devices in children, talk about some indications and goals, look at the devices that are currently available, highlight the outcomes, and also some of the complications. So this is really the timeline of pediatric bad therapy. The Berlin Heart X-Score was originally developed in Germany in the 1990s, with the first case reports of it being used in North America in the 2000s. Over the course of the early 2000s, there was work done for approval of the Berlin Heart through the FDA in the USA. And in 2011, we started to use one of the adult-specific devices called the HeartWare HVAD, as well as the HeartMate 2. We began discharging patients from hospital with these adult-type devices, probably around 2012, with the earliest discharges really being in Canada and Europe. In 2017, the HeartMate 3 implantations really started. And VAD became really an accepted form of therapy for advanced heart failure, and with a lot of focus in many centers discharging patients home. And the more recent changes in 2012, the HeartWare was taken off the market, and I'll talk a little bit about how that's impacted our device choices as we go through this talk. So these are the patient populations that we typically use VAD support from. This information comes from the PDMAX registry, which is a North American registry that collects data on VAD implants in almost 50 centers across North America. So in general, the most common etiology is for individuals with cardiomyopathy, and that accounts for about 60% of the patients, with dilated being the most common. Congenital heart disease accounts for about a quarter of the patients, with many of those being single ventricle patients. Myocarditis about 10%, and then about 5% other diagnosis. The indications typically used to think about VAD implantation is for a patient who is inotropic dependent and starting to show end organ dysfunction. And that could be the form of respiratory failure, so either say dependent on CPAP or BiPAP or intubated. Those with worsening renal or hepatic function. Those who are unable to mobilize as they are so deconditioned from their heart failure, and those inability to tolerate feeds. And although not on here, the other common symptom that we often see is neurological impactment from heart failure, with children being quite irritable in those with a low cardiac output. Another way to look at this is the patient profiles, and these patient profiles really originate from the PDMAX registry. And there's 7 different profiles, with the PDMAX level 1 being critical cardiogenic shock, so those with life-threatening hypotension despite rapidly escalating inotropic support and critical organ hypoperfusion. And then, for instance, PDMAX 7 is advanced New York Heart Association 3, so those clinically stable on oral therapy with a reasonable level of activity and potentially distant history of decompensation from their heart failure. But the patient profiles that are really seen in the pediatric world in terms of who gets a VAD are really the first 3 PDMAX profiles. About 30% of the patients are in PDMAX level 1 or critical cardiogenic shock. About 55% are classified as PDMAX level 2, which is progressive decline. So those would be patients on inotropic support with a pretty good blood pressure, but they have ongoing issues with nutrition, so inability to tolerate feeds, start to show some renal and liver dysfunction, and may have issues with volume overload that you can't manage with your typical diuretic therapy. And then there's a smaller proportion of patients, so about 12% when we look at the PDMAX registry, who are PDMAX level 3, which are stable but inotrope dependent. So these would be patients on mild to moderate doses of inotrope, but you can't wean the inotropes off because they get hypertensive or worsening symptoms. Now, this PDMAX level 3 is not as common because typically we have left patients on inotropes because we believe that the risk profile of being on inotropes was less than a VAD. But as the VAD therapy has improved and complications have decreased, there are people that are moving patients such as adolescents on inotropes towards a VAD therapy where they can be discharged home from hospital because the risk profiles are better than they have been in the past. Whatever devices or whatever the patient profile is, one of the things that you have to ask yourself is really what the strategy is for this patient. So why am I implanting a device? Is it because I think this patient may recover? Is it because I want to bridge them to transplant? Is it because this is a bridge to candidacy? So you're not really sure which direction they're going to go, or if they would be a candidate for transplant, or could this potentially be destination therapy? And you can see by the percentages that are on here, this is kind of the breakdown in PDMAX as to how patients were labeled at initial implant. So most of the patients are a bridge to transplantation, so about 50%, or a bridge to candidacy for transplantation. But regardless of what the initial intent is, patients can really change categories. This is somewhat arbitrary in some ways, but as we know, there could be a patient that was a bridge to decision and then it ends up being their long-term therapy as opposed to a bridge to transplant. Or there could be a patient that was initially bridge to transplant and then decides that they actually want this as their long-term therapy. So these are somewhat arbitrary, but in some ways helps you kind of decide what your initial VAD is going to be, because a patient for bridge to recovery, you may not be putting a long-term VAD in them potentially. No matter which your kind of strategy is or what your patient population is, really the goals of VAD therapy are to improve end organ perfusion, to help rehabilitate, so whether that's from a nutritional standpoint or also a mobility standpoint. And then in that subset of patient is really to look for recovery, because we know that VAD therapy decreases the LV volume, it decreases wall stress and myocardial oxygen consumption, and therefore can help promote recovery. And this may be in patients with myocarditis, could be in patients post cardiotomy. For instance, we've used VAD support in kids who have had L kappa repair with a severe dysfunction to give them some time to recover. When we look at what's happening in North America through the PDMAX registry, we can see that this is a cumulative number of VADs over time. So currently in the registry, there are just over 1,000 patients and 1,200 different devices. And then Action Network is a network that really looks for quality improvement initiatives in VAD patients. And they also have a ton of information. So there's about 12,000 devices in the Action registry and about 1,000 patients. And you can see the various breakdown of devices there. And we'll be talking about a number of these throughout the course of the talk. If we focus just on patients who are bridged to transplant, we know that currently through the International Society of Heart and Lung Transplantation, that over a third of patients are bridged to transplant on some form of mechanical support. The most common mechanical support used is a left ventricular assist device, with ECMO really only accounting for about 3% of the transplants. And that in some ways makes sense that we've moved away from using ECMO as a source of bridging strategy, as we know that patients post-transplant actually have worse outcomes if they have been on ECMO, and that the complication profile of ECMO increases really every day that you are on it. When we look at the age groups, we can see that the use of mechanical circular support is really almost equivalent across age groups, whether they're less than 1 year of age or 11 to 17 years of age. It's really in about a third of patients are being bridged to transplant with some form of mechanical support. And then from a diagnosis perspective, and this parallels the information in the PDMAX registry, where the majority of patients who are being bridged to transplant are those with dilated cardiomyopathy. And this is true when you break down the patients by age and diagnosis within every age category. It's more common for patients with dilated cardiomyopathy to be bridged than congenital heart disease, although there is a certain percentage kind of in each age group. And we'll talk a little bit about congenital heart disease in a few of the slides coming up. So these are our current device options. So short-term devices are really PDMAX PediMag and CentraMag, or in some centers, the Rotaflow. And although they're deemed short-term devices, that's basically stems because of their FDA approval for 30-day use. We have definitely used these devices for a much longer period of time, up to 8 months. And there's been other centers who have used these kind of shorter term devices, longer term, usually with stable cannulas, such as the Berlin heart cannula. The Impella is also being used more commonly in pediatrics to date as well. And then for durable devices, it's the HeartMate 3. Used to be the HeartWare, but as I mentioned, that's taken off the market, and the Berlin Heart X-Core. And then also there is a small percentage of patients who may be implanted with a total artificial heart. So how do we decide which device for which patients? This is really just kind of my opinion, but it does reflect kind of our practice here. And I think a lot of what's happening across North America. So I'll just walk you through this. Obviously, each patient needs to be considered with their underlying diagnosis, what your goal of therapies are, and whether they have other comorbidities that need to be managed. But this gives a kind of a basic approach to looking at mechanical support in patients. So if you think that their support time is going to be less than 2 weeks, you could consider ECMO. That for sure is something that we do, for instance, in a patient with fulminant myocarditis, as we know that if you don't have recovery within kind of the first 10 days or so, you're unlikely to recover, but we will use ECMO as a number of those patients will be able to come off. Or you can consider a temporary VAD, such as the Impella or a PediMag, CentraMag, Rotaflow, for instance, with bypass cannulas. For patients who you think need a little bit longer duration of support, so we'll say greater than 2 weeks, you have to try to one of the deciding points is whether or not you think they need an LVAD or a BiVAD. Some of these are interoperative decisions, but for simplicity's sake, if we say we're going to go down the road of an LVAD, then typically we would use the Berlin Heart X-Core in those less than 25 kilos. Now, in the past, it used to be less than 15 kilos because the HeartWare was much smaller than the HeartMate 3, and we could implant a HeartWare down to 15 kilos. But now that that's off the market, our cutoff is probably around 25 kilos, although people are trying to push that down. The HeartMate 3 then would be used for those kind of greater than 25 kilos. Its profile inside the chest is much bigger than the HeartWare, and that's why it's a bit of a challenge to get it in smaller patients. We also will use CentraMag and PediMag for longer term support, as I talked about. This is especially true for patients who may need renal replacement therapy or an oxygenator. It does sometimes help to estimate flow. There are some patients with congenital heart disease who have a high collateral burden, for instance, and it's hard to know exactly how much flow you may need to support them, and this is one way to estimate that. In some occasions, we remove the mitral valve, and therefore we need a form of continuous flow, and the Berlin Heart X-Core is pulsatile, and so we may use the CentraMag and PediMag in that case. And then some certain single ventricles, especially with significant AV valve regurgitation, we may start off with a continuous pericorporal device like the CentraMag or PediMag. And then if from a BiVAD support, our options are Berlin Heart X-Core, the total artificial heart, which is limited by really the chest size, and then again, CentraMag and PediMag. Most of our data on the outcomes in pediatric VAD come from PediMax, which is North American registry, Euromax, which is a European registry, and then the Action Network, which is a quality improvement network for individuals with advanced heart failure, including VAD. I'm going to focus mostly on the outcomes from the PediMax registry, but there are a lot of good publications on the Euromax as well. So with the recent 2021 fifth annual report for the PediMax, we know that the overall survival for VAD therapy is about 80% at 3 months and about 70% at 12 months. And this includes all ages, all devices, all diagnosis. This is made up of about 41% being intracorporeal continuous flow VAD. So that would be your adult type VADs like the HeartMate 3 and HeartWare, pericorporeal pulsatile, and about a third, and that would be the Berlin Heart, and pericorporeal continuous, which would be those individuals with, for instance, a CentraMag or PediMag. We have learned a number of lessons through the data collected So we know that younger patients may fare worse than older patients. This is not necessarily a reflection of age. Some of this has to do with diagnosis, because there is often a higher proportion of patients with congenital heart disease in the younger age groups. And we also know that the sicker you are going into VAD, the worse outcomes. And so we try to avoid implanting patients who are in critical cardiogenic shock, because we know that their outcomes are worse. So if we can catch them before they get into that state, then that's where we try to pull the trigger for VAD therapy, because we know that their outcomes are worse. If we look at device-specific outcomes, a lot of the mortality actually comes from these paracorporeal continuous flow devices like the CentraMag or PDMag. These are all competing outcome curves. So if you take any time point, so for instance, at 6 months, you can see what proportion of patients fall into each individual outcome. So at 6 months after support on a paracorporeal continuous VAD, about 8% of patients are alive on VAD, 35% have made it to transplant, about 30% have died on the device, and about 25% have recovered. And so if we compare that, for instance, with the implantable continuous devices like the HeartMate and HeartWare 3 at 6 months, you can see that the transplant rate is much higher, 60%, and the death rate is much lower, 8.3%. So I think a lot of the overall mortality we see in this pediatric registry really comes from the paracorporeal continuous devices, and that has a lot, when you kind of dig down into that a little deeper, younger patients and a lot higher percentage with congenital heart disease. And this is just kind of showing that. So the top graph shows those with cardiomyopathy, where the death rate on device at 6 months is 10% versus congenital heart disease, where it's 31%. So for the pulsatile devices, the Berlin Heart, we're just going to do a couple slides on congenital heart disease, just to focus, to give you an idea of kind of what the information is out there, and also some of the improvements potentially that we're seeing in supporting these patients. This is a study that was published by Dr. Morales in Cincinnati, who looked at patients who had congenital heart disease and who had surgery during the same stay as their VAD implantation, versus those who had a VAD implanted in a different stay after their surgery. And as you could expect, those with congenital heart disease had worse outcomes than those with non-congenital heart disease, but that's not really what I wanted to highlight. What I wanted to highlight was this slide. So strikingly, those patients who had congenital heart surgery during their index hospital stay had only a 22% survival. But if you had congenital heart surgery at a different time, your survival was much better. So for instance, there's this bar here that's ECMO without congenital heart surgery in the same stay, and the survival was 82%. So I think that this really speaks to the fact that VAD therapy does not have great outcomes if you're using it as a rescue therapy following kind of a failed palliated surgery. And with this in mind, the team in Gainesville, Florida, has really started to try to implant VADs earlier in congenital heart patients, especially single ventricle patients, as really part of their first stage palliation. So they identify higher risk patients. So for pulmonary treatment intact septum, for instance, it would be those who have evidence of ischemia and significant coronary issues. And then for other patient populations like hypoplastic left heart syndrome, it would be those with ventricular dysfunction or severe AV valve regurgitation who have signs and symptoms potentially of low cardiac output. And they use these, they put the VADs in at the same time that they're doing part of their palliative procedure. So for hypoplastic left heart syndrome, for instance, they would do PDA stent and bilateral PA bands, and then an RA to PA cannulation. And through their experience, they have shown that they can have pretty good survival. So 83% in those that were bridged to transplant. And that is that most of that group, majority of that group, are those who had the VAD implanted during kind of their first surgery. And they too show that if you use it as a rescue therapy, so that was in 3 patients, that the outcomes weren't very good. They were able to support these patients for quite a period of time, for instance, up to 167 days. And they saw mostly hemolysis and infection and inflammation as their main complication. So this kind of experience is kind of shifting people's thoughts as to when to implant these devices. We know that if you do it too late, the outcomes aren't great, but we're starting to see a signal that if you can implant early, you may have better outcomes. And this is encouraging because the first publication on single ventricle outcomes, especially in stage 1 patients, there was almost 100% mortality. And that was published a number of years ago. For continuous flow devices, the focus, we're just going to look specifically a little bit of information on the HeartMate 3. This is older data. There should be a paper hopefully coming out in the next few months on an updated analysis from the ACTION network. And really this device is just being implanted in the last year or two in pediatrics. This was an early experience through ACTION with 27 patients. The median age was about 15 years and weight about 65 kilos. And the most common diagnosis was a dilated cardiomyopathy. The smallest patient in this cohort was 27 kilos. Through this small series anyways, didn't have any patients who had stroke. They had no pump thrombosis and a low incidence of bleeding and only one patient who died. So really good early outcomes. And I can tell you that the subsequent outcomes are pretty good as well. And so you can watch out for that paper. I think that should be coming hopefully in the next couple of months. So we don't only need to understand survival in patients on VAD therapy, but it's also important to understand the burden of potential complications. For years, we've had a good understanding of the complications for adult paracorporeal pulsatile devices, which no longer really exist, and then continuous flow devices. And if I had given this talk maybe 5 or 6 years ago, we didn't have as good understanding on pediatric complications, especially those with continuous flow pumps. But now through the work of all these different registries, we have a much better understanding of complication rates. This is just a summary slide, which I like from the ACTION network. It doesn't tell you about individual pump outcomes, but it does tell you as a network with these 1,000 patients and 1,200 devices that the stroke rate is 11%, which is pretty remarkable because in the past, most stroke rates have always been reported to be up to 20 to 30%. The bleeding rate is 19%, and this is across 42 different centers. Infection rate about 26%, device malfunction about 7.5, and mortality 12.3. So we've really seen a change kind of in risk profile and complication rate over the last number of years in the pediatric VAD world. We can narrow this down a little bit more, and this data comes from the 5th annual report from PDMAX, where we can look at paracorporeal continuous VAD, so that's like the central mag and rotoflow, the pulsatile devices, Berlin Heart, and the continuous flow devices, which is really the Heartware and HeartMate 3. Where bleeding is about a third of patients across devices, and an infection is much less common in the adult type devices. Neurological events, which includes anything like delirium or seizures, are more common in the paracorporeal continuous and pulsatile devices, but our stroke rates have come down quite a lot over the years, with a 14% stroke rates for paracorporeal continuous and about 15% for a paracorporeal pulsatile, and 8% for those continuous flow VAD. So really encouraging change in this complication rate. That was something that we still worry about, but was much more significant in the past. Now, we know that there's complications with VAD therapy, and really the question is, can we make improvements? And there has been some efforts over the last few years to make improvements, and I'm just going to highlight a couple of those. So the first one was really the anticoagulation strategy, especially for the Berlin Heart, started in the 90s and really never changed over the course of time. We started using Bival in our Berlin Hearts probably about 6 or 7 years ago. Bival, as many of you may know, is a direct thrombin inhibitor. It inhibits thrombin by reversibly binding both the active site and fibrinogen binding site. And it has a half-life of about 20 to 30 minutes. So we started using this drug as we were requiring escalating doses of heparin and still having lots of clots and fibrin deposits in the Berlin Heart. And when we started talking to other centers, there over the course of years, a number of centers who also started to use Bival. And so we got together our early experience of Bival in centers. So this was 43 children at 10 different centers across North America. with the median age of support about 9.5 months. About 53% had transitioned from ECMO, and half of them were kind of in critical cardiogenic shock. These were the devices that were included in this retrospective analysis, and the median duration of support was about 57 days. And in this early report, about 16% had major bleeding, 12% had stroke. And at this time, the stroke rate was reported about 20 to 30% in most of the trials. And then our pump exchange rate was lower than had been reported. And this is also what Berlin Heart was reporting at the time, that their pump exchange rate had decreased from 1 point pump exchanges per patient to 0.251. And this is all in the era when BiVAL was starting to be used. So with that in mind, through the Action Network, we came together to really try to decrease stroke rate across the network in general. We focused on anticoagulation strategy, which was really BiVAL, targeting blood pressure, and having a communication tool with teams so everybody knew what the target blood pressures were, what the target anticoagulation was, and to kind of highlight also any neurological symptoms that the patient would have, so that if new neurological symptoms came about, we would know that we needed to early look for stroke. This was our harmonization guideline that we came up with of how to use BiVAL therapy. And these are the early results. So in this particular quality improvement project, we had 11% stroke rate in 407 patients. And so to do that across many different centers to show kind of this consistency is really impressive. And this is really where our stroke risk sits today for the Berlin Heart. And these strokes were really early on after implantation. So what is the future? There are many things we could potentially talk about in the future, but the most exciting thing is the Berlin Heart X-Core, which is a mobile driver. The currently way that you support the Berlin Heart is with an ICUS, and the ICUS only has a 30-minute battery time. So patients in our hospital wait up for a year and can only be unplugged for about 30 minutes a day. The Berlin Heart X-Core driver has a battery life of anywhere between 6 hours and 13 hours. So really is going to change the quality of life for patients in the hospital waiting for transplant. And we were really fortunate that we were able to just recently acquire special exemption through Health Canada to put our first patient on it. And this is the first patient in North America on the Berlin Heart X-Core Active. So in conclusion, VAD therapy has continued to improve the survival outcomes in children with end-stage heart failure. Improvement outcomes need to continue to focus on small children, especially those with congenital heart disease. And morbidities are common, and collaborative efforts are ongoing really to make ongoing improvements. Thank you.